Now let's talk about measuring a patient's pulse. Oh, that's okay. What's the most common pulse site for both children and adults?
The radial pulse.
That's right. And how are pulse rates measured?
In beats per minute. And you place your fingers, do you mind?
Oh, not at all. Go
You
ahead.
place your fingers over the artery like this, so that the fingers are flat against the skin.
Very good. Just be sure not to just press with the fingertips. And remember, you can use the same technique for other peripheral pulses too. Melissa, how about respiratory rate, and how is that measured?
By counting the number of breaths per minute.
That's right, and you should also watch the depth and the rhythm of the breathing. Plus, it's always a good idea to move right from the pulse measurement to counting the respiratory rate so the patient isn't aware that you're counting their breaths.
Is that because a patient may change their breathing habits if they know they're being monitored?
Exactly, and that might cause the measurement to be inaccurate. So let's get started. Mark, why don't you and Katie go meet your patients, and I'll trail Melissa for a while and catch up with you a bit.
Sounds
Okay?
good.
Great, thank you.
Have fun. Relax.
All right.
So my patient has been running a bit of a temperature for the last few days due to a wound infection. The nurses have been checking her vitals, blood pressure, temp, pulse, respiration every 4 hours, and it's about time for another reading.
Good. Do you have the right equipment?
Well, let's see. In order to check her vitals, I'm going to need my electronic thermometer, and probe covers, blood pressure cuff,
Very good.
a watch, and a stethoscope. So yeah, I think I'm all set.
I think so too.
Good morning, Mrs. Lewis. I'm Melissa King. I'm a nursing student, and this is my instructor, Miss Scott.
Mrs. Lewis?
How are you feeling today?
Well, not bad. I'm just feeling a little clammy, though.
Yeah, okay, well, we'll see if that fever's broken. We're going to be taking your temperature, pulse, and blood pressure. That okay with you?
Fine with me.
Okay. I'm going to close the door to give us some privacy.
Okay.
A little hand hygiene. Right. So I'm going to check your ID bracelet real quick. Okay.
Good. So the first thing you're going to do is check Mrs. Lewis's chart just to see how often the temperature, pulse, and respirations are taken.
All right.
Good.
It says here they should be at 4-hour intervals.
Okay. Oh, so that's round about now. Okay. Now, sometimes nurses make the decision to check the vital signs more frequently. It depends on the patient's condition.
Okay.
Okay.
Well, should I wear gloves?
Oh, now, see, that's a very good question, Melissa. You need to wear gloves when there's a possibility of coming in contact with blood or bodily fluids, or if the patient has excessive secretions coming from the mouth, or if contact precautions are being observed. But in Mrs. Lewis's case, gloves aren't necessary.
So I'll just check the thermometer, make sure that it's working properly.
Good, good,
I take it out of its pocket.
good.
I put it in the probe covers till it snaps. And then I place the thermometer under Mrs. Lewis's tongue in the posterior sublingual pocket.
Very good, yes.
Okay, Miss Lewis, if you don't mind me, just, raise your tongue a little bit. How's that? All right, close down on it. Okay. I'll wait a couple seconds. Okay, all done. You can open up now.
Good. Now be sure to dispose your probe cover, and then you'll want to record your reading on Mrs. Lewis's chart.
Right.
Okay.
So it's 97.3.
Good. 97.3, Mrs. Lewis. Very good.
All right, so we're going to move on to pulse now, if you don't mind.
Fine.
You can take your wrist here, and with my first, second, and third fingers, place it on the radial artery, and then with my thumb against the back of the wrist, up against the radius
That's
bone,
right.
just enough pressure to feel the pulse in the artery. Then with my watch, I'm going to count the number of pulsations within a 30-second period,
That's right.
noting the rhythm and the strength of the pulsations.
Right. Then you multiply the number of pulsations times 2 to get the per minute pulse rate. However, if the pulse is abnormal in any way, you'll want to count for a minute. Okay? All right, let's get started.
Okay. Very good.
Very good, Melissa. I noticed you went right from counting the pulse to observing the rise and the fall of her chest. You remembered. And there again, you count for 30 seconds and multiply by 2 to determine breaths per minute. And if her respirations are abnormal in any way, you want to take them for the full minute. You have to remember that. That's very important. You want to chart that down?
There it is.
Very good. Good. Okay.
Okay, Mrs. Lewis, now we're going to move on to blood pressure.
All right.
Now, we take a patient's blood pressure only after they've rested for at least 5 minutes. And you also want to make sure that the patient hasn't smoked or had any caffeine for at least 30 minutes.
Mrs. Lewis, have you had any cigarettes or coffee in the last half hour?
No, just a little juice and some oatmeal.
Oh, good, good. Now, in this case, we can measure using either arm. If there were a dialysis catheter or any venous access devices like a PICC line or an implantable port or an intravenous access, we have to use another limb.
Okay, I read that you shouldn't take blood pressure where there's a surgical site or on the same side as a mastectomy.
That's right, that's right.
Okay, so I'm going to clean my stethoscope with the alcohol swabs and we can begin.
Okay, and while you're doing that, I'm going to help Miss Lewis get comfortable. Okay, good. There.
Okay, Miss Lewis. So I'm going to take your arm, raise it at heart level, palm up so I can locate the brachial artery. I'm going to undo this for a minute so I can expose your upper arm here. And then with my first, second, third finger, palpate to find brachial pulse,
Yes.
which is right there.
Okay, you
All
got
right,
it?
yeah. Now, blood pressure cuff.
Okay,
Which
now
I'll
line it
line up
up
the-
right.
yeah, right,
Yes,
line up
make
the
sure
bladder
it's
right.
lined up. Good.
The artery.
Good. Good. The lower edge of the cuff should be about 1 or 2 inches above the inner aspect of the elbow, and the tubing should extend from the edge of the cuff near the patient's elbow.
Right.
Now, tell me, what's your next step?
Okay, well, I'll check to make sure the cuff is snug around the upper arm. Then I'll look and see that the gauge is at 0. I'm going to estimate her systolic pressure first. So I'll find the brachial or radial pulse and then tighten the screw valve on the bulb.
Okay, right, right. Now use the bulb to inflate the cuff as you palpate the artery.
Okay.
All right, now take note of the reading when you can't feel the pulse anymore. This is the estimate of her systolic pressure.
Yeah, I couldn't feel it after 128.
Oh, okay, good, good. Now deflate the cuff and wait about 15 seconds. Okay, good. Now palpate the brachial pulse and place the bell or the diaphragm of the stethoscope firmly over the artery. Now make sure that it's not touching the cuff or her gown.
Okay.
Just like that. Good. Now you can go ahead and inflate to about 30 millimeters above where the pulse disappeared when you palpate it. Okay, wonderful. Now slowly open the valve on the bulb and let the air out at about 2 to 3 millimeters of pressure per heartbeat. When you hear the first sound, that's your systolic pressure.
I hear it.
Good, good. Keep deflating until the sound becomes muffled. And then continue to deflate until the sound disappears. Now, you might hear them together or separately, but once the sound disappears, that's the point of a diastolic pressure.
It's gone.
Okay, what did you get?
126/68?
Good, good. Now let's go ahead and completely deflate the cuff and be sure to document your measurements according to the policy. Now, you do know how it should appear on the chart, don't you? Okay.
It should read 126/68.
Good, yes, yeah.
126/68.
Now, if you've taken a blood pressure other than the brachial site, be sure you mark on the chart exactly what site you use.
Okay.
All right? And be sure to report any abnormal findings to the patient's primary care provider.
Mrs. Little? So this is Mrs. Little. She's recovering from her surgery this morning. The nurses have her on an automatic electronic machine to monitor her blood pressure. Now, do you usually use automatic machines after surgery?
Well, it's often used in acute care settings like during anesthesia, post-op, or anytime frequent assessment of blood pressure is necessary.
Okay.
Now, the unit is set to monitor the patient's blood pressure at preset intervals.
Well, how does it work?
Well, pretty much the same as any oscillatory device. The cuff is applied in the same way with the microphone or the pressure sensor positioned directly over the artery. And how it works, it determines blood pressure by analyzing the sounds of the blood flow through the artery or by measuring oscillations.
That's pretty cool.
Yes, it is. Yes. See, when using something like this, you have to keep in mind that irregular heart rates, room noise, or even excessive movement of the patient can interfere with the readings. And you also need to make sure that the cuff is completely deflated after the readings.
Now, why is that?
Because if it doesn't deflate all the way, it can cause inadequate arterial perfusion and venous drainage, which can compromise circulation in the limb.
Right.
Let's go. Okay.
I know it's our first day, but I'm really excited to get on the floor. I mean, I'm very anxious to get some hands-on experience.
Oh, I'm so glad to hear that, Mark. It's good to be excited about learning.
So I'm going to need to take a tympanic temperature.
Well, so what can you tell me about a tympanic temperature measurement?
Well, you can use the tympanic route when taking an oral temperature becomes more difficult because it's quick, it's easy, and it's safe. So since my patient has a sore throat, tympanic is probably better.
Good. But you should avoid using a tympanic thermometer when there's excessive drainage coming from the ear or if there's scarring of the tympanic membrane because it can cause problems for the patient. And besides, you may not get an accurate reading.
So can you still use the tympanic route when the patient has an ear infection? Or if there's a lot of earwax? Is that going to affect the reading at all?
Oh, well, not significantly. You just have to make sure when you insert the probe into the ear canal, you insert it tightly enough to seal the opening, or you can pull up on the pinna just a little bit, just straighten out the ear canal and expose the tympanic membrane.
Like that?
Just like that, yes. Okay?
Yeah, let's go.
And you're going to be handling the procedure. I'm just going to be there to walk you through
Okay.
it. All right?
Sounds good.
Okay.
All right.
You're going to do fine.
Hello. Hi, Mr. Shepard. My name is Mark Toludo. You can call me Mark. I'm a nursing student who will be caring for you today. And this is my nursing instructor, Miss Scott.
Mr. Shepard?
Hello.
Hi.
And how are you feeling today, sir?
My throat's still really sore.
Okay. All right. Well, we're just going to have to take your temperature and see how that fever's doing, all right?
All right.
Okay. You mind if I take a look at your ID bracelet?
No, go right ahead.
Thank you. Everett. Give me a moment while I clean my hands and put on a pair of gloves.
Good. I'm glad you remembered that because you're going to need to remove the probe after it's been in Mr. Shepard's ear. Very good, Mark.
Thank you.
You're welcome.
All right, Mr. Shepard. Now, this is a tympanic thermometer. I'm just going to put it on the inside of your ear for just a second, okay?
Okay.
Okay, now remember, Mark, gently insert the probe in the ear.
Could you please look to your right, Mr. Shepard?
Okay.
Thank you.
So it'll make a seal. There you go. Now angle it towards the jawline. Good. Press the button on the handle and wait for the reading.
98 degrees.
Very good. 98.
Looks like we got a hold of that fever. Looks like
Okay.
it's getting back to normal.
Now, what I need for you to do is make a note of it on his chart and also put the site down. Okay?
Yep.
There we are. And remember, any abnormal findings, report it to the patient's care provider. Okay? Mm-hmm. All right.
So now I have a patient who came in with an infection and dehydration, and the doctor has requested that we do a rectal temperature.
Rectal temperatures are thought to be one of the most accurate temperature measurements. However, you should try to avoid this site whenever it's possible because it can be very uncomfortable for the patient.
You think he's uncomfortable?
Okay, so you have everything?
Yeah, I think I have all the equipment I need right here.
Okay.
I have the electronic
Good.
rectal thermometer, the probe covers, the water-soluble lubricant,
Good.
the box of tissues, and gloves. I need a pair of gloves.
Oh, no, they're in the room.
Okay.
Okay.
All right. Mr. Jordan? Hi, my name is Mark Toludo. I am a nursing student, and this is my nursing instructor, Miss Scott.
Mr. Jordan?
We're just going to need to take your temperature rectally. It will only take a moment.
Oh, yeah, my doctor told me something about that.
Okay. Here you are, Mark.
Thank you.
You're welcome. So, let's check his ID.
All right.
Okay.
Excuse me. Okay, Jordan.
We're going to raise the bed a bit to get him a little more comfortable working height, all right?
Okay.
And then we're going to work together to move him on his side.
No problem.
Okay. All right.
Now I'm just going to move the sheet just enough to expose his buttocks.
Okay, let's lift this sheet right here and roll him to his side. We're going to roll you to your side, Mr. Jordan. You're doing fine. There you are.
Okay.
Okay. Now place the probe cover on the thermometer. Okay, and apply 1 inch of lubricant to the probe. That's it. Okay, Mr. Jordan, you're going to feel us touching you? Okay. It's going to be fine. Now, sphincter is clearly visible. And now you're going to insert the thermometer to 1.5 inches into the anus. And remember, for a child, it would be about 1 inch, okay?
Now I'm just going to wait for the beep.
That's right. Okay, you can remove it now. Gently, gently. Okay. There, now get your tissue.
Going to use a tissue to remove any excess lubricant or feces from the anus.
There we go. Are you all right, Mr. Jordan?
Yes.
Okay, we're about finished. Okay, all done, Mr. Jordan. Now. Okay.
All right.
Okay, we're going to roll you back now, Mr. Jordan. Be sure to enter the reading on his chart. Okay, there. I'm going to pull your bed back up, okay? There you are.
Here we go.
Okay. Thank you, Mr. Jordan.
Thank you.
Thank you, Mr. Jordan.
Thank you.
Have a good day.
You too.
Thank you. Thanks.
And I think you did very well for the first time.
Thank you. Thank you very much. I was a little nervous.
Wow, that's only normal to be nervous.
But
But,
I just experienced.
but you had the patient comfortable, and that was important. And there you are. Mark, you and Melissa continue with your patients while I work with Katie, and I'll catch up with you later.
That sounds great.
Okay.
Thanks a lot, Miss Scott.
Bye.
See you later. Bye, Katie.
See ya.
Well, Katie, you ready for me to see your patients with you?
As ready as I'll ever be. What are we going to be focusing on today?
Well, I thought we'll start with axillary temperatures, even though it's the least reliable of all the sites. But sometimes we have to use a patient's axilla to get a temperature reading.
When would you measure an axillary temperature?
For the most part, you measure an axillary temp when the oral, rectal, and tympanic readings aren't possible. And in this case, your patient is on a number of IV medications that are making her throat and mouth sore and inflamed with ulcers.
So an oral temperature reading is just out of the question.
Right. And a tympanic thermometer might increase the pain she's been experiencing from her stomatitis.
What about a rectal temperature reading?
Well, normally that would be okay. But her white blood cell count has dropped to a dangerous level. So an axillary reading is the best choice.
Okay. Hello, Mrs. Stevens.
Oh,
Hi.
hello.
I'm Katie Roth. I'm a nursing student, and this is my instructor, Ms. Scott.
Mrs. Stevens, hi.
How you doing?
We're going to be taking your temperature today, if that be all right.
Yes.
Okay, great. I just need to take a look at your ID bracelet. Okay, thanks. And I'll just pull the curtain a bit.
Miss Stevens, you look a little uncomfortable. Can I help you? Can I get you anything?
No, that's all right. Thank you.
All right.
Have you had your bath today, Mrs. Stevens?
Yes, I had it about an hour ago.
Good. It's very important that we wait about 15 to 30 minutes after a patient has had her armpit washed before taking an axillary temperature. Okay, so I'm just going to pull your gown back a bit here.
Okay, Katie. Now be sure you place a probe cover on the thermometer before you get your reading, okay?
Right.
Okay.
Okay, I'm just going to lift your arm up a bit.
Okay, good. Good
Great.
placement.
Okay, all done.
Okay.
Great. 99 degrees. Thank you.
Okay, 99 degrees, Miss Stevens. We hope you feel better. All right.
Thank you.
Now, Katie, I need for you to note the temperature and the site. Okay. And also remember, if you have any abnormal findings, you must report it to the patient's care provider.
Okay,
All right?
great. Thank you.
Thank you,
care.
Mrs. Stevens. Feel better.
Thank you.
Okay, bye-bye.
Bye-bye.
The medication requires that the heart rate be at a certain level before administration. So
Then I open the clamp on the piggyback set.
Right. You'll be able to regulate the flow using the roller clamp on the primary tubing based on your drip calculations.
All right. 33 drops per minute. Okay, now that the medication is infused, I can close the clamp on the IV piggyback tubing. Okay. And readjust the rate, the primary infusion, using the roller clamp.
And you're finished. Easy. Don't doubt yourself.
What did I say? You the man.
Ah, thank you, thank you. Right. You're all set, Mr. Redding. The medication should help stop your nausea when the meal comes.
Rock and roll.
That means goodbye.
Thank you, Mr. Redding.
See you later, Mr. Redding.
Tamika, I'd like to look in on your patient that's receiving intravenous antibiotics.
Okay, sure.
What will you be doing?
I'm going to be administering my patient's antibiotic with a mini infusion pump. That's also known as a syringe pump, right?
Right. And what will that entail?
That means the pharmacy mixed the medication in a syringe. So I'll be inserting the syringe into the pump, which is connected to the primary infusion tubing. And the pump delivers the medication using a mechanical pressure applied to the syringe plunger.
You seem pretty comfortable with the procedure. Ready to administer?
Are you sure you don't want to?
What is it with you guys in this? You're so confident in the information, but you...
It's just, it seems so complicated sometimes with the syringes and the adapters and... sometimes it feels like I can't fit anything else into my head.
Just relax. It takes some time to feel confident in everything. But you're very bright, Tamika, and I have a lot of faith in you. I'm here to help, okay?
Thank you. That's very reassuring. Okay.
All right,
let's do this. First, I check the medication order against the original order. Check for allergies and any inconsistencies, observing the 3 checks and 5 rights, then gather my equipment.
Okay.
The MAR, the mini pump infusion tubing, alcohol swabs, and tape. The syringe pump is in his room, right?
Keep going. You're doing fine.
Okay. So I read the MAR and retrieve the patient's medication from the patient's drawer and compare the label on the medication with the MAR. That's check 2.
Mm-hmm.
I'm going to infuse it over 30 minutes, which is the prescribed infusion time. Compare the information one last time, and that's check 3. Then we're off to see the patient.
Here we go. Good job.
Okay.
There we go.
Good morning, Mr. Nixon. How are you? This is Miss Swenson, my instructor. She'll be observing, okay?
Pleasure.
Now, I have an antibiotic for you. Would you mind if I administer it now?
No time like the present, I say.
Okay. I'd like to check your ID band and compare it to the MAR chart. What's your name, please?
My name is Robert Nixon.
Excellent.
Did you check to see if the antibiotic is compatible with the primary IV solution?
Yes, I already checked, and it's compatible. So, Mr. Nixon, I'm just going to check your IV site for inflammation and infiltration, and it looks fine. So, we're ready to get started. So, I'm going to check the syringe for air bubbles, and I don't see any. But if I did, I would expel the bubbles from the syringe. Next, I attach the syringe to the mini infusion tubing.
Nicely done.
And fill the tubing with medication solution by firmly pressing against the syringe plunger.
There you go.
Now, I'm inserting the syringe into the mini infusion pump with the flange of the syringe in the clamp's groove.
Now use an alcohol swab to clean the medication administration port on the primary infusion tubing closest to the patient and connect the mini infusion tubing.
With that done, I program the pump to the correct rate, in this case over half an hour, and press start.
You should assess Mr. Nixon and the pump about 5 to 10 minutes after the infusion starts to make
Okay.
sure everything's working properly.
Okay, cool. We'll have a nice chat.
All right, I'll leave you to it. Looks like things are under control. Thank you.
How are you, Mr. Nixon?
Great.
Hello. Now that the infusion is complete, you can press the off button on the pump,
Okay.
disconnect, and properly discard the tubing.
Okay. Next, I'll recheck the primary infusion and document the medication administration.
Very good, Tamika.
Everything okay, Mr. Nixon?
Great.
Great. We're all set. I'll check back with you in a bit, okay?
Thank you.
Thank you.
Can you grab that and we'll take that with us and discard?
It was really good.
It's all right. It was worth it, I'm sure.
Are you ready for my next patient?
You bet. I know you have an intravenous medication to administer. It will be given using a volume control administration set. What is that exactly?
Well, that's when the medication is diluted in a small amount of solution in a volume control set and administered through the patient's IV line, right?
Ah, another unsure student. What is it with you guys? Must be something in the water. Of course you're right.
I'm sorry. There's just concern about the possibility of giving someone too much fluid intravenously, which always makes me nervous.
Why it's being given with a volume control administration set.
Right.
Why don't you gather your supplies and I'll meet you in the prep room in a few minutes.
Okay.
Thanks, Robert. Looks like you've got all of your supplies.
Yeah, I think I do. The MAR, of course, the medication, a needleless syringe, the volume control set, which is already in the room, and alcohol swabs and a medication label.
Very good. So first,
Well, first, I checked the MAR against the medication order. I also calculated the drip rate for the prescribed infusion time, in this case, 40 drops per minute. Now, I used the MAR to identify the correct medication. And I compare the medication label with the MAR.
see, look at you. Next.
Well, next, I'm going to withdraw the medication into the syringe. First, let me wipe the tip here. Okay. Okay. I'm ready.
And then what?
And I rechecked the label against the MAR.
Great. Then you'll want to prepare a label for the volume control administration set.
Oh, the label's right here. It's already been prepared by the pharmacy.
Good. You know, the label should include the patient's name, ID number, medication name, the name and volume of the solution for dilution, and dose, date, and time. And you're going to double check all of this against the MAR.
All right. I think it's set. Let's do it.
There's the confidence.
Hello.
Afternoon, Mrs. Parker.
Good afternoon.
How are you feeling?
I'm doing quite well, thank you.
Oh, good. I'm here with my instructor, Miss Swenson.
Hello.
To administer an antibiotic. Is that okay?
That sounds fine. I have no problem with that.
Good. Let me take a look at your ID band.
Good idea.
Okay. And tell me your name.
Sylvia Parker.
Good. I'll just clean my hands. I'll be back.
Great idea.
So you feeling a bit better?
I am doing quite well, really.
Good. Glad to hear it.
I like.
You're in good hands.
All right. I'm back.
Robert, did you check the compatibility of the antibiotic with the primary IV solution?
Oh, yes, I've checked. They're compatible.
Okay, thank you.
Okay, let me take a look at your IV site. Looks like it's free from infiltration and inflammation. Okay, so first, I begin by opening the clamp between the IV solution and the volume control administration set. And then I fill the chamber with the prescribed amount of solution to dilute the medication, in this case 40 cc's. And there it goes. Then now it's okay to close the clamp. There we go. Now I take an alcohol swab and I clean the medication injection port of the volume control set.
Oh, very good, dear. I am impressed.
Thank you. Now I...
It's time to remove the cap from the medication.
Oh. That's right. Let me put this down. Okay.
Insert the syringe into the port.
Okay.
And inject the medication into the chamber.
And then you agitate the volume control chamber to mix the IV solution with the medication.
That's exactly right.
But how did you know that...
Oh, I was an RN for 15 years. I'm retired now, but, you know, some things you can never forget.
Then use an alcohol swab to clean the injection port on the primary IV infusion tubing closest to the patient.
And then, if I remember correctly, you insert the tubing into the injection port.
Absolutely right.
Good.
Thank you.
And then you finally open the roller clamp on the volume control device tubing.
Okay.
And regulate that flow based on your calculated and prescribed rate. And then attach a label to the volume control device.
Right again.
Oh, how fun. Oh, hi.
Hey, Mrs. Parker. How's it going?
Good, good.
All right. Ladies, my turn.
Oh, all right.
Now that the infusion is finished, I close the roller clamp.
Uh-huh.
I remove the volume control device.
Very good.
Okay. And I recap it. Then I recheck the flow rate of the primary infusion.
Very good.
Thank you. All right, Mrs. Parker, is there anything else we can do for you?
Well, now that you mention it, perhaps you could bring by some other nursing students. I'm sort of enjoying this teaching thing.
Will do. You have a nice afternoon.
Thank you.
See you later, Mrs. Parker.
See you. So nice to see you. Good luck.
Thank you very much.
So, yeah, that's what I was thinking.
Here's the rest of my gang. Hello, ladies.
Hi.
Miss Swinson. How's everybody?
Good. Fine.
You guys are all doing really, really good work today, and I know you each had some concerns about your abilities, but you showed real confidence, even if you needed to ask for help. Next thing I'll be observing with Paula is something I thought we should talk about briefly. It involves administering a medication through an IV lock. And what is this device?
It's a venous access device used for intermittent IV medication.
A little more simply?
It's a device where a patient is connected to an IV line and when it's time to receive the medication, and is connected when the medication is completed.
Great. Now with these, IV placement must be confirmed before using the medication. And be sure to use positive pressure when flushing with saline to prevent clot formation in the catheter, okay?
Right.
Okay, Tamika and Robert, I'll see you in a little bit. I'm going to help Paula get ready for her next patient.
Okay.
All right. Good luck.
Good luck.
Good luck. Thank you. Okay, first unlock the med card.
Okay, I think I got it. Well, my patient receives medication to help control her blood pressure, ordered intravenously. So we'll have to administer it through her IV lock.
Okay, great. What supplies do we have?
2 syringes, both with 2 milliliters of normal saline for injection, alcohol swabs, my watch with the second hand, and the MAR.
Okay, now let's compare the original medication order and check the patient's medical record for allergies. Now, how do we confirm the rate at which the drug is to be administered?
The drug resource book, I looked it up already, and it should be administered over 2 minutes. I also checked her blood pressure, and I made sure that her potassium levels were within normal limits.
Okay, very good. Now, the medication you're administering is?
Furosemide, 30 milligrams IV.
That's right.
Once a day in the morning.
That's right.
Okay. Now I compare the label on the medication with the MAR, using the 5 rates of medication as my second check.
Exactly. And then we're going to recheck the label with the MAR a third time.
Okay.
And then we're all set to take the medication in the syringe and the supplies to the patient's room.
Okay.
Good job.
Thanks.
A 9-year-old Hampshire girl has a new lease on life.
Hi, Miss Hampshire. How are you?
Fine.
This is my instructor, Miss Swenson.
Do you mind if
All
she
right.
stays with us for a little bit?
Well, it's fine.
I have your furosemide for you, and that's the medicine to help with your blood pressure. Since you're not able to take pills, I'm going to give it to you through your IV.
Okay.
Okay, can I give it to you now?
Please.
Okay, let me just wash my hands real quick. I just need to check your ID. And can you state your full name for me?
Hampshire. My name is Joan Hampshire.
Okay, great. I'm also going to check your IV site for any inflammation or infiltration. Looks good. Okay. Now I gently rub the port with alcohol to make sure it's clean.
Okay. Then you're going to stabilize the port with the non-dominant hand.
Okay.
Insert the syringe with normal saline into the port. Then aspirate gently and check for blood return. Now flush with 2 milliliters of normal saline and remove the syringe.
Okay.
And what next?
Okay. I clean it with alcohol, make sure it's very clean. Then I insert the syringe with the medication, very gently. Okay. Using my watch to verify the correct infusion rate, in this case 2 minutes.
Remember not to force it if you feel any resistance, okay?
Okay.
Okay, now you can remove the medication syringe. Wipe your port once again.
Nothing's wrong at all, Miss Rogers. This is Miss Swenson. She's my instructor. We'd like to care for that wound of yours. Your pain medicine's had enough time to start working, so we'd like to cleanse it thoroughly and put on a new dressing.
Oh, my pain is much better now.
Great. It's okay if Miss Swenson observes, right?
Oh, sure. I don't mind that you're here, Miss Swenson. It's no problem at all.
Thank you.
I'm just going to check your ID band. Oh. And can you tell me your full name?
Helen Rogers.
Okay, great. Miss Rogers, do you have any allergies?
Not that I know of.
Okay. I've already washed my hands, so I'm just going to put on some clean gloves here. Oh, I see you already have a waterproof pad underneath of you. Okay, do you mind if I pull the covers back?
Oh, no, go ahead.
Okay. Now, I'm going to loosen the tape on the old dressing.
You might need to use adhesive remover to get the tape off, Jeannie.
Oh, I think I'm okay. It looks like it's coming off. If any of the dressing were to stick to the underlying skin, I'd be sure to use small amounts of sterile saline to help loosen and remove.
Be sure not to reach over the wound.
I will. Here we are, it's all off. I'll just dispose of it.
Now, what should we be taking note of?
We should note the presence, amount, type, color, and odor of any drainage that's on the dressing.
Exactly, and then we'll document that in the patient's chart later on.
Take your time. There's bound to be a problem. There always is with me.
It appears to be healing, Miss Rogers. Now we'll get ready to clean this up. I'll prepare a sterile field and open up the supplies.
Depending on the amount of cleaning needed, the solution could be poured directly over the gauze for a smaller procedure like this, or in a basin for a larger procedure.
Now I'll put my ointment on my gauzes. Now I'll put on my sterile gloves. And I'll start cleaning the wound.
Clean the wound from top to bottom and from the center to the outside. Following this pattern, use a different gauze for each wipe and place the used gauze in the waste receptacle. And don't touch any surface with the gloves or forceps, Jeannie.
Now I'll dry using a gauze sponge in the same manner. Now,
the antibiotic ointment. Now I'll put a layer of dry, sterile dressing on top of the wound, and then the ABD, or Surgi pad.
Very good. And now?
I'm going to remove my gloves because it'll be easier to tape without them. I'm going to make sure I document the date and time on the tape of the dressing.
Things look very good here, Miss Rogers. Thanks for letting me observe. You're in good hands.
Oh, I know.
Okay, taping this up and you'll be all set.
And when you're finished with that, Jeannie, you'll document the procedure, your wound assessment, and the patient's reaction to the procedure.
No problem. Okay, I'm going to cover you up.
Okay.
Excellent work.
Thank you.
Thanks.
Hi, Miss Swenson.
Hey, Tamika. Hey. I'd like to follow you on to your next patient.
Sure, no problem.
Can you give me a rundown on the situation?
Yeah, my patient's admission orders are to do a culture of the wound before her antibiotics are started.
That's right. If a wound appears to have signs of infection, it may be necessary to do a culture in order to determine its cause.
Why is that exactly?
Identifying the invading microorganism helps us determine treatment options and select the most appropriate treatment. That's why it's so important to maintain strict asepsis. Right. This will help identify only the pathogen present in the wound and prevent external contamination.
Well, I've got all the supplies we need.
Looks like you're ready. Let's do it.
Okay. Hi, Miss Olshan. Hi, I'm back.
Good to see you.
This is my instructor, Miss Swenson. She'd like to observe today. Is that okay?
Oh, it ain't nothing. The more the merrier.
Okay. What we'd like to do is take a culture of your wound to make sure we give you the best medication for your infection. So can I do that now?
Oh, well, I'm not going to argue with a professional.
Okay. Well, I'm going to clean my hands.
Thank you. It'll help us make sure we're giving you the most appropriate treatment.
Okay, Miss Olshan, what I'd like to do is clean the wound, get a culture of the wound, and then redress you, okay?
Sounds good to me.
Okay.
Always make sure you have the proper culture swab, Tamika.
Okay. I'd like to check your ID band, okay? Tell me your full name, please.
Tabitha Olshan.
Okay.
You see, I'm a dog person. I've never been into cats. Oh, their little eyes, they're always thinking about something. And you know they're not thinking about if you're happy the way dogs do. Oh, no. They're always plotting something. Apparently, I got a little too close when it was hatching its plan.
Yes, you did. Let me reposition the bed to make it easier for me to remove the dressing and clean your wound. Okay.
Thank you.
Okay, I'm just going to put this waterproof pad underneath your wrist. Thank you. Okay, all cleaned up. Now I put on clean gloves.
Check the label against the patient's ID.
Then I twist the cap to loosen the swab in the culturette tube, making sure not to contaminate the swab or the inside of the culturette tube.
Very good.
Then I carefully insert the swab into the wound and roll it to obtain a sample.
Now, Tamika, since you have a second wound, you'll use an additional swab to obtain the other culture.
Okay. Now I'll carefully replace the swab into the culturette tube, making sure not to touch the swab to the outside of the tube and secure the cap.
Very good. And place the label on the tube.
Now I'll get these gloves off and replace your dressing.
Are you going to get me Thousand Island instead? Or blue cheese?
Just a couple more minutes, Miss Olshan, and we'll be finished, all right? Okay, Tamika, you've replaced the dressing. Right. Now you should label your specimens with the date, time, and your initials.
Okay.
Then we'll put them in the biohazard bag and send them to the lab. And of course, you'll want to document the procedure, your assessment, and the patient's response to the treatment in the chart, which is at the nurse's station.
Okay.
Thank you. Great job.
Thank you.
Thank you, Miss Olshan.
Thanks,
Take
Miss
care.
Olshan.
Now make sure you come back. My door is always open.
Thank you.
What's going on with your patient, Robert?
Okay, I'm going to irrigate the pressure wound on my patient's heel to clean it when the dressing's changed.
Remember, it's important to protect the tissue around the wound when using moisture in order to prevent any further tissue damage.
Oh yeah, I remember that from class. And the nurses are using a skin barrier around the wound. He also has pain from the wound when the dressing's changed. So he's received the prescribed pain medication about 40 minutes ago.
Very good intervention. Pain management is important. All right, let's take a look at the supplies you've gathered for the procedure. Looks like you're prepared.
Thank you. I'm ready to go. Hey, Mr. Tedesco. How you doing? Doing okay?
Good.
Well, you told me your pain medication has started to work. Is it all right to do your dressing change now?
I know you.
That's right, sir. I'm Robert, a nursing student caring for you today. This is my instructor, Miss Swenson.
Hello, how are you?
We're here to help you with your foot. So we're just going to clean it up and remove the old bandages, okay?
Okie dokie.
All right, give me a second. I'm just going to cleanse my hands.
Are you comfortable, Mr. Tedesco?
Oh, I'm fine.
Let me take a look at your ID band. Can you tell me your name?
Joseph Tedesco.
Okay, good. Now we're just going to shift you a little bit, okay, just to make you more comfortable while I work.
Roll me wherever. I'm at your disposal.
I'm just going to lower the head of your bed real quick. There we go. How's that?
Good.
Good. I'm going to raise you up. Okay. Now I'm going to ask you to roll to your left.
Okay, Robert, remember to position him so the irrigation solution will flow from the upper end of the wound to the lower end. And you want to put your waterproof pad directly under the wound area to help protect the bed.
Okay, sounds good, Miss Swenson. I'm going to put this behind you here, Mr. Tedesco. Okay. Are you warm? Would you like a bath blanket?
I'm fine.
Okay, good. Okay, now I'm just going to put on my gown, my mask, and eye protection because of the potential for splashing. Then these clean gloves to remove the soiled dressings.
Okay, Robert, let's assess the wound for its appearance, any drainage, and the appearance of the surrounding tissue.
Okay, looks good.
Okay, Robert, let's set up your sterile field now.
Okay. Let's put my supplies on the table.
All right.
Let me just put on my sterile gloves.
Good job. Now we pour warmed, sterile irrigating solution into the sterile container. If any irrigating solution remains in the bottle, date the solution bottle. Open bottles for wound care are usually good for 24 hours, and they can be reused. Now, Robert, remember, your right hand is now contaminated.
Okay, thanks, Miss Swenson.
Okay, now you can fill your syringe with sterile solution. Now we'll put the sterile basin under the wound. Okay, I'm just going to pull this off so it doesn't get into the wound.
Okay.
Hold on to it. There you go. Thank you. All right. Using your non-dominant hand, you're going to apply pressure so it pushes up against the foot and sort of forms a seal, okay?
Okay.
And this action will prevent the fluid from leaking as you irrigate.
Here I go.
Gently direct a stream of solution into the wound.
Hey, man, that tickles.
Sorry about that. This will just take a second.
Be sure to keep the tip of the syringe at least 1 inch above the upper tip of the wound. Gently flush all the wound areas. How do you know when to stop irrigating?
When the solution from the wound flows out clearly.
Exactly.
How's that?
I think we're there.
Great.
Okay, now you'll dry the surrounding skin with a sterile gauze sponge and apply a new sterile dressing to the wound. Okay.
Sounds good.
And when you're finished, you'll document the procedure, the wound assessment, and Mr. Tedesco's reaction to the procedure. Oh, there you have it. How are you making out, Jeannie?
Well, my patient's receiving warm, sterile compresses several times a day to her wound.
And why is that?
Well, to promote circulation, encourage wound healing, and to decrease pain and discomfort at the wound site.
Does she have pain from her wound?
Well, she gets intravenous pain medication prior to her wound care. Her nurse gave it to her about 20 minutes ago.
Very good. I'm glad you used foresight and intervened to control her pain before we started the dressing change. Now, how do we begin?
Well, I checked the order for solution type and frequency and length of time that the compress is to be applied. I've got what we need here, and on the way to the room, we can stop and pick up the foil-wrapped compress out of the warming device.
Great. Follow me.
Hello, Mrs. Estevez.
Hello.
Miss Estevez, this is Miss Swenson, my instructor.
Hello.
She'd like to observe while I do wound care. Is that okay?
Of course it is. Is it really a wound? I thought it was more of a large scratch. Wounded sounds like I'm a wounded animal.
Well, I'm sorry about that, Mrs. Estevez. We use the word wound for any opening on the skin, but I understand. I'll try not to use that word around you, okay?
Thank you.
All right, I'm going to look at your ID band. Could you tell me your full name, please?
Rosemary Estevez.
Okay.
What are you looking for before you start this procedure, Jeannie?
Well, I'm going to assess for circulatory compromise in the area where the compress is going to be applied.
Right. This includes looking at skin color, checking pulses distal to the site, and noting the presence of edema and sensation.
Okay. Do you mind if I pull the blankets back now? Okay. Okay, it's a good pulse. I'm going to put the waterproof pad underneath your leg. Thank you. Okay, I've already washed my hands, so I'm just going to put on clean gloves now. I'm going to remove the old dressing. You might feel the tape pulling just a little. Are you in any pain?
No, that pain medication really does the trick.
Good. Okay, now I'm going to assess the wound. Oh, I'm sorry, I mean scratch. For any inflammation, drainage, skin color, ecchymosis, and odor.
Odor? Lovely.
It actually looks pretty good. The redness around the open area seems to have decreased. So I'm just going to open up my compress now. Thank you. I think I'm ready for the sterile gloves. Now, I'll gently and carefully mold the compress to the open area. I'll apply a layer of gauze on top. And I'll cover it with the bath towel. Would you mind lifting your leg again? Now I'll start the clock. Mrs. Estevez's treatment is for 20 minutes.
Also monitor the condition of the patient's skin and their response to treatment, Jeannie.
Okay. I remember that heat is not to be applied for more than 30 minutes at a time.
And what will you be looking for when you remove the compress?
I will be checking the skin condition, the patient's reaction to the heat application. I'll note any changes in the wound or scratch. And then I'll put on a sterile dressing.
Very good.
Okay, I'm going to cover you back up. Do you need anything else?
No, I think I'm fine. I know I can be a little difficult. Thank you for being so accommodating.
You're welcome. No problem.
Thank you, Ms. Estevez.
Sorry, guys.
Oh, I'm
Hello,
so
everyone. Everybody exhausted?
Not too bad.
You all did really, really well with your wound
Thanks.
procedures today. Everyone remember those all-important rules for sterile technique?
Yes.
Let's say in the case of Jeannie, cleaning the wound with your patient went well, but what if, Robert, you were removing a dressing from an abdominal surgical site during wound care? The chart reported the incision was clean and dry, the wound edges were approximated with the staples intact, but after you removed the dressing, the incision edges weren't approximated. There were multiple staples evident in the old dressing, and the surrounding skin and tissue were red.
And there was purulent drainage on the dressing and in the wound site?
Okay, now what do you do?
Well, I'm kind of stumped. Shush.
First.
Shush. Well, at this point, I would assess for signs and symptoms such as pain, shortness of breath, and pressure in the abdomen. Ma'am, between 0 to 10, 0 being no pain at all and 10 being the most pain you've ever felt, how would you rate your pain?
About a 6.
And what else?
Well, I would place the patient in a supine position to reduce pressure in the abdominal area and prevent further wound separation and rupture.
So what's that called again?
That's known as dehiscence and evisceration, right?
Well, then I would place a dry, sterile dressing on the wound site and get a set of vital signs.
Then you might want to take some time to reassure the patient.
Well, how would you reassure the patient?
Well, I would explain that her wound has changed, but that she's all right. And then I would say that I was going to immediately notify the healthcare provider of my findings. Everybody clear on that?
Yeah.
Yep, sounds good.